Hi, everyone. Welcome to this morning's event, both to everyone who's here in person at the Huron County Museum, as well as all of the folks that are zooming in online to listen to the proceedings. My name is Mike Beazely. I'm a research chair at Gateway in the area of rural substance use. I'm also an associate professor at the School of Pharmacy at the University of Waterloo. And I think it's almost my third anniversary as a Geriatrician resident, so thanks. The Gateway Lecture Series, which this is part of, started during the pandemic and as a monthly lecture series online that brings in various local and national speakers to talk about issues related to health and living in rural environments. Today is the first live lecture series event. So we've got folks here at the museum and online, and we've got a big group that will be listening in today. We've also got a lot of interesting things to talk about. We're going to talk about history. We're going to talk about music. We're going to talk about healthcare workers and their well-being, and we're going to talk about caring for older adults and dementia. We'll bring up the speakers. We'll have two sets of two speakers. With questions after each speaker. So I will be moderating questions here from the live audience, and I'll also be checking the questions that you're posting online. So feel free to post questions there, and I'll try to get to those as well. Just a few housekeeping things. Washrooms are out the door and down the stairs to your left. We also have accessible washrooms out the door, up the elevator on your right if you need an accessible washroom. So we will introduce our first speaker. It's David Yates. David's an award-winning author and columnist. Since 2007, his popular local history column has appeared in several area newspapers. David enjoyed a 30-year teaching career at Huron County high schools, served 17 years on the Geriatrician Town Council, and in his words, and I agree, most importantly, raised 3 kids with his wife, Catherine, in Geriatrician. He is the author of several books in Huron County about Huron County history. His most recent book, Gothic Huron, has received critical acclaim. So please join me in welcoming David, who is going to talk about the origins of professional healthcare in Huron County.
Thanks, Mike, for those kind words. And good morning, everyone. I'm going to talk a little bit about, and I'm only going to skim the surface. I'm going to talk a little bit about progression to professionalism in healthcare in Huron County until about the turn of the last century. Hey, now, we were kind of fortunate because one of the founders of the Huron Tract was, of course, a medical doctor. But with this, I mean, he did serve as a doctor for a while. He graduated from the School of Glasgow and Edinburgh Medical School, so very, really good qualifications, high-quality qualifications. For the time, he wrote a book, a pioneering book on medical jurisprudence, and he joined the Army and became a surgeon in the War of 1812, where he also wrote about doing amputations. Really interesting reading, if you could stomach it. But when he came to the Huron Tract, he moved on from the medical profession. That was kind of common, even though he was schooled as a physician, probably the best schools at the time that you could go to. It wasn't something that held a gentleman's interest. And when he came here, he saw himself more as an official with the Canada Company, a military officer. He called himself the wilderness savant sort of thing, and a literary man. He never practiced medicine here. And when he died in 1848, he was a canal supervisor, a little bit different than being a physician. He was a canal supervisor on the Rideau and Lachine canals. And of course, he's buried over on the other side of the river there. That was not atypical, though, for men of his class to, even though they were educated, to kind of eschew being a physician. It wasn't something for a gentleman, it would be later in the Victorian age, but it wasn't something for a gentleman of his rank to pursue as an occupation. And remember, most doctors in this time, right up until 1900, most people that claimed to be doctors were never educated in a professional medical school. They tended to be apprenticed to other people, and they saw their Tiger probably saw, or Dr. William Tiger Dunlop probably saw his education not as a profession, because that's for the lower classes, but as something that he could say he was educated and schooled in, even though, as far as by all accounts, he was a very competent doctor for the time. Okay, so that leaves in healthcare, that leaves most healthcare in Huron County. We're a sparsely populated, very rural area, more rural than now on the frontier. That left most healthcare in the home. And midwifery, in Canada, most people weren't born in the hospital right up until the 1950s, late 1950s, I think, before most people are born in a hospital. Midwives in the 19th century, the Victorian age, were who you relied on for childbirth, and home remedies. And here are some of the ones that show up in the early papers. For female, the pink pills, they solved everything. These cure-alls, panaceas, they solved everything. The one on the left was for ED, erectile dysfunction. You got to wear a yellow electric belt that you strapped on, and it was supposed to excite the nether regions, and you only had to pay when cured. And Dr. William, if you read all that about Dr. Williams' pink cures, it could cure anything, any ailment that you had. And the fact that these devices and gadgets were in the papers, and the same papers, and advertised for so long, indicates that people had a lot of faith in them, and maybe on some it had some sort of placebo effect, perhaps. We don't know, but they were in the papers throughout the 19th century and beyond, these cure-alls. Okay, and then, of course, there's the others that did have some therapeutic effect if it was taken in mild doses, but laudanum is a common, believe it or not, we talk about drug and substance abuse and addiction now, but it was, and it's hard to know for sure, but laudanum, which of course was an opium extract, you could buy almost over the counter for most of this period. Then they tighten up a little bit, but you really only had to go in and ask a pharmacist, can I have some? And he was always happy to oblige. And you could see it was addictive. Overdoses were commonly reported in the paper. I suspect a lot of the laudanum overdoses were people who were suffering in terrible pain. The chief constable for Goderich in 1907, John Ewell, is said to have died of they said in the paper. And when they found his body, several empty bottles of laudanum were seen around him. He had suffered from a terrible earache, they thought, but it could have been something far deeper. And was his overdose accidental or deliberate? Well, we can't know. Other than he was in a lot of pain. It was reported he was in a lot of pain beforehand. But as the century progressed, I should mention, laudanum becomes from something that you gave to your colicky baby or anything like anybody at home that had any sort of ache and pain, they got laudanum. But as the century progresses, the 19th century that is, they realized laudanum had addictive and dangerous qualities that they wanted. In fact, the Women's Christian Temperance Union, we think about them about alcohol, but they actually raised the alarm on opium-based drugs like laudanum and opium itself. Okay, and by the end of the century, we're starting to come to, we still started to get these, what they called sciences. One of the scientists was phrenology, where you'd go to a doctor and he'd read the bumps on your head to tell what your IQ or what your personality would be like. a lot of doctors, or people that claimed to be doctors at the time, thought phrenology was a science like psychology. And even right up into the 1890s in Huron County, in this building, actually, there is a principal giving a lecture at a conference, a teacher's conference, on phrenology. Presumably, you could tell or place a student in your classroom by the bumps on their head. This gentleman here, Dr. J.M. McLeod, that picture was taken about 1897. He is considered so important in Goderich for McLeod's elixir. Once again, he was trained at the University of Edinburgh. He was a skilled doctor, medical doctor, as professional for the time as you could almost ask for, but he sold, once again, one of these cure-all elixirs. And he had all these testimonials in the paper from real people that said that taking his elixir would cure everything from private diseases all the way up to cancers and almost anything. And he'd go into his lab. He lived on Cambria Street. He'd go into his lab and mix up an elixir and give it to one of his patients or for somebody that sent away for it. Was he sincere? Almost certainly he was sincere that his elixir worked. I don't think he was defrauding anybody. And in 1897, the town of Goderich put together a book called, and some of you may have seen it, it's a souvenir of Goderich, advertising the town of Goderich. If you've seen that book, you know what I mean. He was considered at the time so important that he was an advertisement. Having Dr. McLeod here was an advertisement for the town of Goderich, and so they included him as one of the important men celebrities of Goderich at the time. I did ask some of the women who taught chemistry and science. I said, "What is this stuff?" Because he sometimes listed the ingredients, and they said, "This is almost like poison." I don't know if anyone died from taking it, but one of the neat thing is in Huron County, hotels are incredibly important. And in the 19th century, every town has hotels, and they were far more than they are now. Now they're just a place to stay. But 150 years ago, these were places where medical people, some of them were, most of them perhaps were quacks, but a lot of them were legitimate. If you had a specialized interest in helping somebody, this might be your only chance at health care you can get. You get a doctor, and one of the ones I kind of followed around, I can't remember, he trained at the University of Buffalo, and he went around New York State, upstate New York and southern Ontario, and he was truly a specialist in putting together trusses, ruptures, and treating and that sort of thing. And he'd go around and he thought of his mission as trying to alleviate somebody else's suffering. So what he would do is he'd go to a hotel or go to a town, advertise ahead of time the days he was going to be, say, in Goderich or Seaforth or Exeter. He advertised, "I'm going to be at this hotel on these days," and keep hours between this time and that time. And you go in and you report and make an appointment. A lot of them were just quacks, but there were real medical people that were itinerant, that traveled around and trying to heal people or alleviate their suffering. And the only place that they could do it was in a hotels. Dentists are famous for that. I didn't even mention dentists in my presentation, but they have an interesting kind of trajectory during the 19th century. As I said, you could read everything from, and actually the interesting thing is we had doctors that performed abortions in the 19th century. They'd put out coded messages in the papers, and they tend to keep hours after dark. And they'd mention that. And almost everybody knew what that meant at the time. And I'm sure a lot of young women went to see a doctor in the middle of the night to have that procedure performed. Sounds scary, but there were legit doctors that did that. Okay, but as the Victorians move on, they begin to think society has a duty to help other people. We got to train doctors better, medical men. By the 1860s, they start demanding that trained medical doctors get licensed and they get so that they could sign death certificates and things like that. And the Victorians also kind of thought, you know what, we have institutions like jail, and our jail here wasn't just a penal institution. They took in unwed mothers, pregnant mothers. They took in the insane. That's where we housed the mentally insane. But the Victorians, they began to think we have a duty to help other people. And in Huron County, one of the outcomes of that was what we called the House of Refuge, or the Poor House, which is where Huron View is today. It was built and opened in 1895, and to us it would be just horrific because you put the insane, the mentally challenged, the elderly that had nobody to look at them, dementia patients were all housed in the House of Refuge. But it was a tremendous advantage. You could just go up to the museum here and asked to read some of the psychiatric cases, and they're just heartbreaking. And the jailer at the time, I can't remember his name, but the family seemed to be very kind and understanding of people who were quite seriously mentally ill. In the 1870s, it's only the London sanatorium that houses mentally incapacitated people for this area. That House of Refuge is not from Huron County. There is a picture of it, and I couldn't find it when I was assembling this in the last couple of days, but it's something that looked like that. It closed in 1939 when Huron View opened, but we do know there is at least 128 burials from the House of Refuge in behind the Huron View home. A lot of elderly people for generations didn't like going to Huron View because they associate it with the House of Refuge or the Poor House. There we go. Okay. Now, we had people, and on that progress to professionalism, this woman here ought to have a special place. Liza Greta Eggert was her name. I didn't even put, oh, there she is. Liza Greta Eggert Gretter. She was born outside of Bayfield. Her father was a surgeon, and then during the Civil War, he enlisted in the Northern Army and was a doctor in the Civil War. She grew up in the Civil War. Her husband, after the war, she married a U.S. Marshal. He died young. And for whatever reason, she decided to go into nursing. She turned nursing into a profession. The Farron School, the first professional nursing school, was started by her. She wrote the first couple textbooks on professional nursing, and she also wrote, now this you wouldn't say today, but they used to, if some of you were nurses, you might have remembered when you had your pinning night or your pinning pledge, the Nightingale Pledge. She wrote that. She's credited, she formed a hospital service for the Spanish-American War, and she cut quite the figure in medical circles, especially for females. She made nursing into a respectable profession in North America. And she died in 1951, just over the border in Michigan. Okay, there she is there. Remember that name. And here are some other Huron County women who impacted healthcare and medicine. Dr. Harriet Brooks, she was born in Exeter, went to school in Seaforth. She only went into medicine, or she only went into science and medicine because she wanted to take Greek and Roman history, but women couldn't take it in the third year at McGill because the subject content was too delicate for them. So she ended up going into medicine, and she studied with Marie Curie, the Curies, and Lord Rutherford. She and who was the third? She basically studied under the big three physicists of the time. She died in Montreal in 1933. She was experimenting with radiation as cancer treatment. The other one, Dr. Jenny Smiley, outside. She was born on a farm outside of Hensel. When she was 5 years old, she asked her mom, can women become doctors? And her mom said yes. And from that day, even though that was like 1883 or something, from that day forward, she decided, bent on becoming a doctor, and she had to go to Philadelphia Medical School for Women. And she came back to Canada, was Canada's first female surgeon. and she died at 103 in 1981. Okay. And the other one you have to mention is Dr. Charlotte Whitehead Ross. You know, she was born in England. She was raised in Clinton. That family home still exists in Clinton. And another graduate of the Women's Medical College of Philadelphia. She moved out west with her railroad builder husband. And when she got there, there was absolutely no medical care, no professional medical care. So she set up her shingle. Strangely enough, she had a really neat anecdote when she wrote her autobiography. She recalled how the gentlemen of Philadelphia, her fellow student doctors that were male, how they kind of spit on the dresses and the gowns of the female medical students. But when she went out west, and her clients were basically buffalo hunters, baymen, trappers, railroad workers, tough guys. She said they seemed to really, really appreciate her services. And she said she never felt unsafe. She talks about another one where she was called in the middle of the night to go and take a knife out of somebody's neck and stitch him back up. And she was guided by lamplight from her home to the bar and then back home. And she never felt fear or threatened by any of them, compared to the gentlemen of Philadelphia. But, okay, then, and this is another hero of Huron County Healthcare, Dr. William Gunn. His house stands, it's Kildonan House, and he had a surgery there, and he really, really, really wanted to improve his skills as a doctor. He lived up to the best ideals of a doctor that you can imagine. He didn't let any stone go unturned, and what he did was he specialized in appendectomies. And he'd go to people's houses, and literally he did kitchen table surgery on appendectomies. And we think of appendectomies as a pretty minor procedure today, but at the time it was incredibly dangerous. The Mayo brothers, you know, the Mayo hospitals, the Mayo clinics, the Mayo brothers came to Clinton, stayed at his house to watch him, to study the way he did appendectomies. Okay? He started the first hospital in Huron County. He built it. Very famous architect, Joseph Adds Fowler, designed. That building still stands, not in its original form, of course, but that's it there in Clinton. You might notice it's Victoria Street in Clinton. And that was the first hospital. Women giving childbirth, he had a word for that, accouchement or something. He charged $5 for an accouchement, for a birth, and he had a surgical room. His house he called a surgery. It was like in England they call clinic surgeries, and he set up. There you could read the thing. County Council once in a while gave him a $500 grant, but he ended up, when the war broke out, he left for Europe. He volunteered his services with the Royal Canadian Army Medical Corps, led a hospital in Scotland, and when he came back in 1919, he donated his hospital to the Clinton Hospital so that they could have a hospital until the one that they have now, in the territory they have now, could be built. And I think there was, when in 1923 there was a plaque to Dr. Gunn. And as I said, sadly, with Dr. Gunn, there's his house, there's Kildonan House, you might recognize. Sadly, within about 18 months of this picture being taken, 2 of those children would have been lost. One of them, while he was away on a call in Seaforth. Remember, he had to get on the train, go to Seaforth to answer a call. One of his daughters died, I can't remember which one, of a burst appendix. So, okay. And then you start at the beginning of the 20th century, you start to get the public hospital movement. Believe it or not, the oldest hospital in Huron County, public hospital, is Wingham by about a year. Goderich and Wingham opened a hospital about the same time. The Goderich Hospital here, which was on the corner of South and Britannia, it opened on December 1st, officially on December 1st, 1906, but it wasn't public until the next year when the county decided to fund them. They funded the Wingham Hospital first, then the Goderich one, and then later every town vies to have a hospital. Clinton's next in 1923, where the McTaggart family, he was a banker, he donated his house to the hospital to build a hospital. They lost a son in the First World War, Major McTaggart, their son. Story just on him alone, but their son was killed after he won the DSO twice, a very hard award to get. He was killed like within a couple of weeks of the end of the war. Okay, and what might have been another pioneer, and this is the last slide, I promise, was Dr. Alex Moyer. He'd been a medical doctor. He practiced out west, came back to Hensel, practiced on King Street in Hensel, had a thriving practice, but he became interested in in how radium could cure cancer. And he had a theory. He built his own hospital. He wanted government money, but the government said no, but he did. In 1931, he built his own hospital about a mile south on the Huron Road. The hospital stood, or the building stood, until the early 1990s. You might, I don't know who lived in it. It was a yellow brick building, and there's a nice little stream or creek right beside it, right by the Big O. You know that? Right across from the Big O, he had his hospital, and he thought it was really important that the hospital look like a home and it be located out in the country, because he thought a patient's healing would be strongly connected with nature. He didn't like the institutionalized setting of what hospitals look like, that white stripped down look, and he wanted hospitals to look as homey as possible, and they should be out in nature so that the patients could walk if they could, or be wheeled out, and that was part of the healing process, he thought. Environment was really important. People came to him across the area because he used radiation to treat cancer. Now, unfortunately, at the time, most of his patients that came to him were in an advanced stage of cancer. And but he did have some success. He did have some success in treating cancer patients. The government cut him off of his supply of radium in about 1938, even though they gave him a clean inspection. When they came around and inspected, they cut him off from radium, and he ended up closing his hospital in 1940. Last thing he did is he offered his hospital, and he said he'd be the doctor for patients, or not patients, but for kids getting away from the Blitz, right? Escaping from the Blitz, he offered his home as a refuge. He died in 1940, and they're in a really interesting experiment in healthcare for the time. Now, some of the stuff he talks about would be considered just normal stuff. But that's going to end my presentation for now, and if there's any questions that I can answer. All right. Thanks. Sure. Can I just get there?
So we'll maybe have a question from the audience here. And I'll check online. Oh, don't have any questions.
Okay. Very good.
Okay.
I have a question.
Okay.
Just to remind you, I need to restate the question for the virtual attendees. So when hospitals first started around the Great Wars War, was it a place where people would view it as a place where people go to die? Or was it a place where people go to get better?
Well, I can't put, I'd say, by the time anyone thought of taking somebody to the hospital, they were probably really, really sick, right? Dr. Shaw, who lived in Clinton, he was 90 odd when he was still practicing medicine. Most people went to their doctor before they went to the hospital. And Dr. Shaw was giving birth. Most people, like if you were pregnant, you wanted to give birth. You went to Dr. Shaw, you didn't go to the hospital. You go right by the hospital, you go to Dr. Shaw because he's your doctor. And if you were sick, you go to Dr. Shaw's place first. Because remember, you go to the hospital, you got to pay. Most people had to pay. So you go to your doctor who you trusted and you knew better. And you'd go and you'd see him. There's that Dunedin Manor up in Brussels. The doctor owned that, and people said, well, right up until, if you were born in Brussels until 1965, you were probably born in a room on the top of that house. I don't know how pregnant women, 9 months pregnant in labor, got up all those stairs at Dunedin Manor, but they did, and he gave people look to their doctor. See, you can't go to the hospital. If you live out in Goderich Town, if you lived in Holmesville and you really thought you needed a hospital, you might, like today, you can call 911 and get an ambulance, but then you had to rely on somebody either to take you to the hospital or ride into town to tell somebody, like a doctor, to come out and see you. So people, if they had the convalesce in a hospital, after World War I, everything changes. People start to see hospitals as the primary place where you go. But, you know, for a couple more generations, people are still looking at their local doctors as their primary caregiver, not the building. You didn't want to go to the building if you could help it. It's probably because of what Dr. Moyer said. Everyone's afraid of the hospital because so many people die there, you know?
So if you can just repeat this for the virtual audience as well, what are your thoughts on why or how the region launched such incredible women HC pioneers, first professional nursing school, first surgeon, etc.?
Can you restate the question?
So what are your thoughts on why or how the region launched such incredible women HC pioneers, first professional nursing school, first surgeon, etc.?
Yeah, that's quite a legacy that Huron County is. What the question was is, what do you think it was about Huron County that launched so many women into a medical career, especially at a time when women weren't considered fit to be doctors? And I don't have a steady, other than that we were a very Victorian era. And if you notice, most healthcare, and this could be said maybe for every area, most healthcare is in the home, and it's mostly women, the caregivers. I could tell you after the Spanish influenza, or during the Spanish influenza, 1919, the stats show that it fell disproportionately on young women. The war fell disproportionately, the casualties of the war fell disproportionately on the men of a certain age, the 18 to 30-year-olds, and the Spanish influenza almost evened that out because the 18 to 30-year-olds, women, are the ones that suffer the highest mortality rates. In Huron County, I've gone and looked at most of the death registers or the death records, and if you were a pregnant female and you got the Spanish influenza, your mortality rate was 100%. None of them that were pregnant that got the influenza survived. But I don't know what it is other than we had a good Victorian educational system here. It seems that promoted things like healthcare, and I wonder how many other areas could point to people who did that, but it was something that was of importance to our aunt, probably because we were so rural. Healthcare was so far, professional healthcare was so far away, and it's thrown on the home that people began, women and men, because we had a lot of males that made inroads into healthcare and improvements, probably because we were so rural and remote, but we did have an educational system, a fairly decent educational system for the time in place, that it encouraged a lot of women to maybe take on something as untraditional for the time as healthcare.
We'll move on to our next speaker, so I'll switch spots with you. Okay. Thank you very much, David. That was fascinating talk. And we have other questions, but we've got to move on to our next speaker, who's Gwen Devereaux. She's one of the founders of Gateway and has been Gateway's president for 15 years. She is filling in for Casandra Bryant, who's actually online with us today. Casandra is a rural studies PhD student and sessional lecturer at the University of Guelph. And she's also one of our research chairs in rural healthcare. Her main body of research is the impact of the pandemic on rural healthcare workers with a focus on mental health and well-being, Her other research areas include rural women-led social enterprise, communication for development, place-based development, and participatory leadership. So please join me in welcoming Gwen to the stage.
Well, thank you very much. David, that was just, like seriously, I honestly, sorry, here, I honestly hate to take time from you because you answered a question for me. My grandfather had cancer, lived outside of Hensel, and he had this treatment. He was one of the first people to get this treatment. And I was always wondering how he got from Hensel to London for that treatment. Never knew. So that's amazing. And to the question about the amazing people, why? There's still really amazing healthcare people here in Huron County. I think it's in the water. They used to say the hockey players here were in the water, so I think it's in the water for our healthcare too. I'm really nervous because I received these slides last night and Cassandra's online and I am by no means the lovely Casandra Bryant. So bear with me, everyone, and you, Cassandra, for sure. But I'm honored to be presenting her research. And as Mike said, she is a research chair at Gateway in rural healthcare workforce. And it's no secret that there's been some tough times here for our healthcare people. And she has, last year in September, Casandra was the keynote speaker at Gateway's Remarkable Healthcare Worker Recognition event. And this event was absolutely lovely. We recognized over 40 healthcare workers who were nominated by their colleagues, community members, for their work as they went above and beyond the call of duty to provide care during COVID times. So it's not been easy everywhere in healthcare, and I applaud Casandra for taking on this research. So she's been in other projects with us, such as the impact of the pandemic on mental health and addiction in the labor market in Huron and Perth, called Be Well, Work Well, and food insecurity and inaccessibility of rural seniors in Grey Bruce here in Perth. But today we're going to talk about her research with COVID-19. And where is Jay? Oh, Jay, you're way back there. Oh my God. And so I'm going to look at you when I'm on a slide. Okay, we got the team. We talked about this. So today we're talking about how COVID-19 affected our healthcare workers within Huron County and over the past 4 years. So a quick fact here, you can see that in the University of Guelph's online library, if you bring up articles on COVID, 1.9 million results. And in comparison to that, a search in the same term from 2000 to 2019 resulted in 1,734 results. So if you look back at SARS in 2002, you would see 670,000 publications. So there is no doubt that there's created a great deal of publications due to COVID-19. Today's presentation will take a quick peek behind the scenes of the academic research, a bit of a snapshot of the work that Casandra is currently doing on her PhD. And good, Jay, very good. So we're going to do a brief summary of the research and the impact of the well-being of our rural healthcare workers here in Huron. And this was a partnership between Gateway and the University of Guelph. And 2 phases of the research. Phase 1, June 20th, when we were only 4 months into the pandemic. And phase 2 in June of 2022. We had a survey of 150 healthcare workers, which is amazing that so many answered at that time. Majority, 75%, were self-identified as women between the ages of 40 and 50, working in primary care or as a paramedic, a technician, or public health social support. The second phase included a series of 26 one-to-one interviews, again with the majority self-identified as women. But this phase also included key informant interviews with professional mental health support staff such as psychiatrists, social workers, and therapists. So Casandra hopes to continue this really important research over the next 10 years to really understand the impact of rural healthcare workers in Huron, to fully see how short and long-term implications of the pandemic. So if you want to see more of this, season 2, episode 13 on our website, called The Cost of Caring. You will see more of Casandra's work on this as well. So what does it look like today with COVID? So this week in Ontario, the provincial public health website, if you checked it, they reported a moderate percentage of positivity at 15.8%, with 113 outbreaks, a hospital bed occupancy of 653 people, and 9 deaths. So COVID's not gone away from us for sure. These are, to me, really alarming statistics. And I don't know about you, but I know several people that have had COVID recently. So it's here, it's certainly in our community. And we're well aware of the profound impact that the pandemic has had on the mental health and well-being of those working in healthcare. We've witnessed the biggest exodus of healthcare workers, some calling it the Great Resignation. And looking at the reports now on the shortage of nurses and PSWs in Ontario, we expect that we're going to need 30,000 by 2028. 2.3 million Ontarians are without a family doctor, and this is very concerning in many communities. If you listen to Ontario Morning, you would have heard this morning they're doing every day this week discussing it. And Huntsville was on this morning, and they basically, so I work in physician recruitment, and what it's being referred to right now is the Hunger Games. And it makes me so sad because one community offers 50,000 signing bonus, the next one 75,000, and away we go. So the number of expected needs of our doctors is 2,500 physicians within the province over the next 2 years. So the question is, how are we going to increase that? So you take rural, and you can just look at this tenfold, because our challenges here in rural, historically difficult to recruit, keeping our homegrown talent at home, and that's a lot of the work we do at Gateway, is to try and keep every one of those students that we have coming through and bring them back. On top of the geographic distance, our transportation costs, our housing crisis, and you don't want to go on. We don't want to go on because we love living in rural, but we do have our challenges when it comes to healthcare. So what's the government's answer to all of this? Well, they've put an additional $128 million over 3 years to boost the nursing student enrollment. That would support 2,000 nurse seats and 1,000 practical nurse seats. Our Canadian Health Transfer funding to the province implemented a Coalition for Action for Health Workers to create the Wellness Together Canada portal, where all of us could go to get some confidential mental health and substance use tools and services for all Canadians, including our healthcare workers. And there is also approximately $10 billion is being directed towards home and community care to improve the quality and safety of long-term care, including additional funds to support wages to increase the PSWs and related professionals. We're also introducing our international trained healthcare professionals. I'm involved in the physicians that are coming into our region, and I'm pretty excited about that. It's the first time I've seen this, and they're amazing qualified physicians. And also we're involved at Gateway with some foreign trained nurses in a project to bring foreign trained nurses in, and I'm very excited about that announcement as well. So this is good news, very good news. But we still know that our healthcare people that are on the job are burning out, and there's difficulty hiring more and more. It's highly prevalent for sure. So with the burnout, compassion fatigue is one of those, and I don't think a lot of us, I know Deb, you can relate to the compassion fatigue for sure. It's very hard working in hospice care. The anxiety, the depression, all come with the job. And I mean, all of us know what the isolation was like in COVID. I think all of us suffered. But in healthcare, every day facing that is incredibly difficult. So another goal of the study for Casandra was to look at how did healthcare workers reach out? Where did they get their support? And initially they relied on their family, their friends, and their colleagues at work. And then as the pandemic deepened, they relied less on their friends and family, and they moved more relying on their close friends, because more resources became available during that time for them to seek help professionally. But yet they came back to their colleagues for the majority of the support. And going back to the $1.9 million research articles at Guelph that we were talking about, if you want to do a Google search, you have to put as many questions in or as many words in as possible. So for Casandra's research, it was rural Ontario, Canada, COVID-19, healthcare workers, mental health. And when she did that, the library at Guelph, she came up with 617 databases. And then from that, only 3 recommended databases. And from that, only 6 articles. So think about that. And one of those articles that I want to highlight is Dr. Leith Deacon, who is also one of our research chairs and a prof at Guelph. He looked at COVID-19, mental health, and rurality, and it published an article in 2023. So this is promising that we got that article. However, you can see by the numbers how few. And so for sure there's a gap, and for sure Casandra wants more and more of this research to occur. So as an analogy, Casandra has shared with her research is based on running is like a start of the pandemic. Healthcare workers suddenly found themselves in a sprint where they were running at full speed over what they assumed a short distance or a short period of time, all hands on deck, trying to figure out what to do and how to do it. However, the sprint morphed into a marathon without a finish line. And as one healthcare worker shared, without the required training to actually do a marathon. So Casandra believes healthcare workers are still running that marathon, considering the immense stress and pressure they have and continue to experience. Mental health and wellness are not to be taken lightly, and burnout will be continuing at high levels. This is difficult to expect our healthcare workers to feel safe, healthy, and happy. So let's take a look at some of the research recommendations for the 6 Canadian rural-focused articles in healthcare workers. And we'll skip right to their recommendations and conclusions. So the summary of this recommendation in these articles is rural healthcare needs to have a voice. We need to foster and support resiliency. Policymakers need to understand the very differences we have. and a call for new studies and empirical research must continue, and to call upon healthcare regions and administrators to utilize the findings on their living and working conditions in rural family physicians, and to guide rural healthcare or relevant interventions for future pandemics, and we will have more. To support the resiliency of healthcare workers by promoting mental health and well-being, and to recognize the value and experience of healthcare nursing students in their recruitment plans. And the last one I love, retired nursing specifically, to reimagine in what ways retired nurses can serve the community and workplace. And there is a lot of opportunity here, and that flexible working conditions are critical. And I can tell you, look at what our retired nurses did during COVID, how they came out and helped in those mass vaccinating clinics. I mean, it was remarkable. Not just the nurses, but the whole community, how they came out and volunteered. But that's another thing that should be written about. I think that's such, you can write about that. You're the history person. And more recently, we were doing some work at Gateway on on the firefighters, so our volunteer firefighters across the county, and we're doing some health screening, and there are nurses actually in this room that have come out of retirement to help with that project, and we so appreciate that as well. So yes, number 9, those retired nurses, they're incredibly important. Yes, yes. So in conclusion, and that's what you'd like to hear, Mike, in conclusion, I'm okay, I'm trying. The research and that of others in the same field can help various government levels and regions, businesses, organizations, communities, etc., to better understand what has happened or is happening and how to respond to this in the future, how to better plan the future. And we must continue to spotlight the critical need for mental health support and overall wellness for our rural healthcare workers. How'd I do, Casandra?
Thanks so much. So we'll have a question from the audience.
Yes, and Casandra could maybe answer
Might be able to.
online. I don't know, can that happen, Jay? Mike?
Just looking.
Oh, well, maybe there's no questions. Oh, here we go.
Just remember to repeat it when she asks.
Okay, well, I can repeat the questions, maybe can't answer them. So over here, maybe first?
Artificial intelligence seems to be the buzz term for all solutions going forward to deal with the huge increase in population in Canada and maybe, all sorts of new research projects. So I'm wondering, is that something that's going to enter into the solutions?
Okay, so AI, and this is a big question, and how is this going to enter into some of our solutions, not just in healthcare though, you're talking in general.
Well, let's keep it to healthcare.
Okay, well, let's keep it to healthcare because, oh, I know Cassandra was going to answer this, but I'm going to answer this one first, just for this region, because at Gateway, you may have, I don't have the information sheet. Sorry, here, but in the information sheet, some of you will have, you will see we now have a new chair. Leslie Walker, Dr. Leslie Walker has just graduated from Vienna on our Rotary, our Godrich Rotary Scholarship. And she is our, you see that? She is our chair in rural AI. So we're pretty excited about that. Cassandra, want to answer?
I'm just texting her now.
Okay, so we maybe could come back and go to the other question then? Sure. Over here, yes, go ahead.
Tell me, I've heard about the money given to nursing students, and you had it written up there, how many $1 million. Is that just for the next 3 years, and is there anything being presented for people going through the doctors?
Oh, well, I can answer that one and not make Cassandra answer that. So the question is, what kind of funding is being offered for nurses going forward and potentially for physicians as well? So the answer to that is it's ever-changing. This funding that was put in place was definitely in response to COVID. And so we've got a lot of PSWs being trained completely financially without any, which is wonderful. There for rural, because I'm always speaking of rural, there is funding for nurses to work in rural for return of service. And for physicians who come out into rural, there is across the board, not just family physicians, but specialists. We in rural areas, they receive funding for a return of service as well. And then the communities are putting money in on top of that.
And I just wanted to add as well, just with my experience at the School of Pharmacy at Waterloo, in the pharmacy world, this shortage and focus on rural and remote recruitment of pharmacists is we're being very active about it. In fact, we've just hired an experiential coordinator for Indigenous, Northern, Rural, and Remote pharmacies to try to get more of our students placed in those environments, and then hopefully with the goal of those students that are placed there to stay there when they start their professional career. And then Cassandra was able to answer the question about AI. And so she says, my only point is that at this time there is little to no published research yet in the rural context in terms of support for mental health and wellness. I'm going to suggest we will see an increase in publications very soon, and with respect to the role of AI in mental health and wellness. So thanks again, Gwen, for your presentation, and Cassandra. So that brings us to our break. And so for those of you that are here in person, we've got still some coffee and I think still a few treats left in the lobby. And for those of you online, there'll be a bit of dead air, but we will get started up again at 11:15. Okay, thanks.
to get this.
Let's start back up. For those of you online, we're just got a few folks trickling back into the room. But we're going to start up again with our next speaker, our third speaker, who is Dr. Alex Peel. Dr. Peel is a geriatrician in independent practice, working rurally in southwestern Ontario. Geriatrician is an internal medicine specialist who cares for people over age 65 with dementia and or frailty. She sees inpatients via telemedicine at 8 rural hospitals and outpatients at her clinic in Wingham or via home visit. Dr. Peel is going to talk about dementia and how to prevent it. 40% of dementia cases could be prevented by addressing modifiable lifestyle factors. So please join me in welcoming Dr. Peel.
All right. So thank you everyone for having me today. And I apologize in advance. I brought a little friend with me today, my middle son, Macklin. Took the day off senior kindergarten to come and see what mommy does at work. So, hi Mac. So you might hear a little extra chair squeaking or loud whispers, but we'll just do our best to keep as quiet as possible while we're chatting. Maybe you should sit right beside Gwen. Right beside Gwen. All right. So, thank you very much for everyone, or for coming today to kind of talk about something that's really important to me, so dementia in our community. And this kind of builds on some of the other talks I've given in previous years on community support services and sort of living in the community for people with dementia and frailty. And then sort of on the healthy aging talk that I did last year. So if we need more information, hopefully those talks are kind of archived to kind of build on today. So my objectives for today is that first we'll talk about all of the modifiable risk factors and how in most cases we actually have the ability to reduce our risk of developing dementia. We're going to touch on how that might be different or how that might be applied uniquely in a rural environment. And then if we have a couple minutes, Jay and Gwen made the mistake of telling me that I could leave people with my soapbox to stand on. So we'll touch a little bit on the gaps in care for older adults with dementia and frailty. So first, just to define the term, what is dementia? So dementia is sort of an umbrella term or a syndrome, and it refers to a decline in a cognitive skill that is severe enough to affect your ability to do things. It's generally progressive over time, and we cannot find a reversible factor that explains that cognitive change. Now, a lot of people then will say to me, well, how is that different than Alzheimer's? Or like, what kind of dementia do I have? So remember, dementia is the umbrella term. There are kinds under it. So Alzheimer's disease, where an abnormal protein deposits in the brain, is considered to be one of the most prevalent causes. Vascular is also very prevalent in our community. And just to highlight down there at the bottom, this concept of mixed dementia is very prevalent and something that I tend to see more frequently in the rural environment. When we do brain autopsy on people with dementia, what we find is that over half of them have Alzheimer's protein and vascular changes. So, what is the biggest risk factor for dementia? So a majority of people, when I ask this question, will tell me that it is genetics. It is your family history. But actually, it is our age. So the older we live, the higher chance we have of developing dementia. But what I don't want you to leave here with is sort of an ageist stereotype that every older adult has dementia. Because if you're sort of a cup half full type of thinker, 1 in 4 people over 85 do have dementia, but 3 out of 4 don't. So, is the risk of dementia increasing or decreasing? So the answer is it kind of depends how you look at it. So prevalence, which is kind of the total number of cases in our population, is actually increasing. And that's because, as we sort of said, the major risk factor is age. We know people are living longer, so the total number of cases is more. That makes sense. The incidence of dementia is actually staying fairly stable in the Canadian context, or possibly even declining. And that's kind of the number of new cases per year kind of situation. And so we're going to talk about why that is and how that's modified. So what % of dementia risk is modifiable? So you heard at the beginning, we talked about how 40%, so the World Health Organization says about 40% of the risk of dementia is modifiable through health factors or modifiable health factors. But in the Canadian context, our newest literature is actually saying that about 50% may be modifiable by health factors. So this is the most recent study looking at the Canadian context. And where this data came from is the Canadian study of longitudinal aging, where they followed over 20,000 older adults across Canada from all walks of life for 20 years and looked at their health and their risk of developing various conditions. And sort of what this figure is trying to show is that sort of these 12 risk factors listed are kind of those big modifiable things that you can work on, but it also shows how dementia risk looks across your lifetime, remember. So there's things that are early life risk factors, then we have midlife risk factors, and then we have late life risk factors. So I think the key takeaway here is just that, when we are raising our children, when we are in midlife, there's a lot of choices that we make at that time that then impact us later. But also when we're already in late life, there's still lots of things we can modify. So in the Canadian context, physical inactivity is one of the biggest modifiable predictors of developing dementia, followed by hearing loss. So the exact pathophysiology between hearing loss and dementia is not entirely understood, but what we know is that people with untreated hearing loss have accelerated cognitive decline. Obesity, and sort of all of the vascular risk factors, and especially high blood pressure. And we'll talk a little bit about some of these other risk factors as well. So how might a rural area differ? So when I was searching the literature for this presentation, I couldn't actually find any studies that look at incidence and prevalence of dementia in rural Canada. There's a little bit of literature from Saskatchewan looking at rural dementia care, which is very helpful, but not much looking at rural communities in general. So we take our information from the United States and other countries that have already started exploring this topic. And what we see is that the prevalence of dementia cases seems to be higher, and the incidence, so kind of that individual risk of dementia, seems to be higher. So general hypotheses of why that might be: in rural communities, people are generally older. We have this phenomena of outmigration of our youth, right? They leave, they go to school, some come back, some don't. We're left with this expanding, aging population. So just to give you, rough figures, like in rural communities, 20 to 25% of the population will be over 65. In urban communities, it tends to be 15 to 17%. So that can vary a little bit, but that makes a huge difference when you're talking about health human resources planning. Things that might affect that, the individual risk. There tends to be less formal education in people living in rural communities, so less people with more than grade 12 education. However, that gap is narrowing. We do tend to see, though, lower levels of physical activity, and that's both exercise and physical activity. I think a lot of rural people think like I have maybe like an active job, which maybe some of them do, but the majority of us are just like everybody else. We don't have that active of a job. Like I know myself, I think I'm on my feet all day. Well, I get about 4,000 steps a day, like in the best case scenario at my place of work. So we know that's a problem in rural areas. We also know that we tend to have more vascular risk factors. So high blood pressure, diabetes, overweight, and obesity. We also know we have higher use of alcohol, and we'll touch on that a little bit as well. A couple other key things that is potentially hypothesized to affect rural populations. We tend to see sometimes lower incidence and prevalence in certain studies, specifically if they're using diagnostic codes to identify dementia cases versus actual community screening. And the theory behind that is that in rural areas, your dementia is more likely to be undiagnosed. Whether that is stigma, whether that's that you don't see your doctor as much or you don't have a doctor, who knows? But when we use that government coding, we miss cases of dementia in rural areas more than urban. The other kind of scary thing that has come out of some of the American studies is that rural people tend to have an earlier age of onset in general of their dementia. And that's not fully explained either at this point. So what's the typical person that I see with dementia coming into my office? Usually they are older, plus 75 situation. They often have fairly extensive vascular disease in their brain and maybe have had, long-standing high blood pressure or maybe sleep apnea where they snore and stop breathing at night. They may have smoked back in their past. They may be slightly overweight. They may have diabetes. So that, not all of those things, but just the vascular risk factors in general. And a lot of times people are consuming more than 2 alcoholic beverages a week, which is the current Canadian guideline, and we'll kind of chat about that. So what is our mission then, if we should choose to accept it, is that we need to identify these 12 modifiable risk factors, work on changing them in early life, in midlife, in late life, develop those specific interventions, and make our population healthier. So what are the key things that a person could do to try to adjust those 12 factors which predict your risk of dementia? So, you'll see different ways of categorizing these different health behaviors. Actually, Randy and Jeanette from the Alzheimer's Society brought these very helpful pamphlets on reducing your risk of dementia, so there's enough for everybody to take. It just kind of goes over these factors in more detail. But the physical activity is a big component. Being socially active in your community, a big component. Nutritious eating, making safety conscious choices. So that's like wearing a helmet, hearing protection, managing our stress and taking care of our mental health, and always challenging our brain and learning new things. So before we get into what a person can do to modify, to change these health behaviors, let's just talk briefly about habit change in general, right? Because I find, people come into my office, they want to know, what do I do to reduce dementia? I hand them a handout, nice one here. They go home and not much changes, right? So how do we change our behavior? There's lots of great books out there, or handouts or websites or things you can read. But what I have generally observed and what generally holds true in the literature is you just want to start with one tiny, small change, something you can change in your daily life and it won't affect anything else in your daily life. And that will drive very big health results over time. So a non-healthcare example, we've got this Air Canada flight. It takes off from Toronto, it's programmed, it's heading the right way to Vancouver. Someone accidentally shifts it 3 degrees. No one notices. 3 degrees, that's not a lot. By the end of that 6-hour flight, all of a sudden everybody's in Portland, Oregon, instead of in Vancouver. So what we need to do, we need to shift ourselves 3 degrees so that we end up without dementia rather than with, right? So key things, so the small change, so like you can do anything for 5 minutes. Like I challenge any of you, you can do anything for 5 minutes. That gets you through university education, at work every day, you know, it's a mantra for your life. Things that, or you want to cue yourself. And what do I mean by that? Say you're telling yourself, I'm gonna eat more fruit and vegetables. Well, like don't have all the snacks in the cupboard, right? You're never gonna pick the fruit and vegetables if the snacks are in the cupboard. So you gotta make it easy, right? You wanna make your cues obvious. So if your running shoes are the first shoes that you see, you know, you're more likely to put them on and go for a 5-minute walk than if they're in the back of the closet. Temptation bundling is the concept of combining a habit with something rewarding. So example, maybe you like watching TV in the evening. Perhaps you could sit on a little exercise bike or get up and walk around on the commercials. But basically that idea of pairing something that has a big reward for you, like TV, with something that maybe doesn't have as high of a reward like exercise. Although for some people they love exercise, right? Habit stacking is another thing. So combining it with something you already do. So maybe every time you go to the grocery store, you walk around the parking lot, you know, one time before you go in, and then you push your cart to the farthest away, you know, grocery stall. Those little things that you always do that you kind of combining with something you already do will make it that much easier to change a habit or build a habit, change a routine. So for physical exercise, what are the recommendations? So we want people to aim for about 150 minutes a week of moderate to vigorous physical activity. It should be optimally in segments of 10 minutes or more. And ideally we would add in a bit of strength and balance training a couple of times a week. And in terms of step counts, like, you know, society has kind of said 10,000. That's awesome if you do 10,000. From the data, what we see is, thank you, helper, poorer health outcomes for people over 60 who have sort of less than 6,000 to 8,000 steps a day. And for those under 60, more like 8,000 to 10,000 steps a day, right? So you could probably get away maybe with a little less than that 10,000, but more is better, and lower than those thresholds is associated with negative health outcomes. So again, going with the health changes that or ways of making change, you know, start small, plan to do an activity for 5 minutes, you know, add 200 steps to your day. Anyone can do that just from walking around their coffee table. You know, choose the stairs instead of the elevator, walk to the mail. You know, think of it as activity, not as exercise. And ideally pair it with something else you like, or maybe meeting with a friend, kind of physical, social at the same time. From a social activity perspective, you know, there's so many things out in our community. I mean, all of you people, case in point, are here today to hear this talk. So you're already, you know, socially active, but many people aren't. So you could join a group or a committee or volunteer, or it could be something small, like having a conversation with the person at the grocery store, right? Brightening their day a little bit, or doing like a random act of kindness, like just walking in to say hello to somebody who you don't see often. Macklin, thank you. So nutrition. People ask me, you know, what's the diet? What's the secret? What do I eat? And, you know, the key, like when we're talking about memory in general, the recommendations, a lot of the research is around sort of a Mediterranean style of eating or something called the MIND diet. But what I've generally found is that people have a really hard time switching their diet, like going from like their usual diet to like radically different diet. So I tend to give people more sort of like general recommendations of things that would shift them from what they're eating now to more of like a Canada's Food Guide situation. So the first recommendation would be drinking water, not juice, not pop, water. That's what our body is fueled by. The next thing is challenging yourself to eat 2 fruits and 4 vegetables. If you eat 2 fruits and 4 vegetables, there's not much room left for like the simple carbohydrate thing. So, challenge yourself to try that. Cooking at home when you can, eating with others when you can, kind of limiting things that are high in added sugar. So I don't mean fruits and vegetables. I mean like the stuff you buy off the shelf. I think a general mantra is if it came from a plant, it's probably good to eat, good for our body. If it was made in a plant, we might have to kind of question its nutritional value. Thank you, everyone, for laughing at my jokes here. So the next piece is just kind of those healthy choices, right? Like avoiding cigarettes, smoke, alcohol we'll touch on, wearing hearing protection if we have a loud job so we don't lose our hearing as we get older, wearing our helmet when we're doing, various sports in midlife. The other piece to that is, just seeing your doctor, like knowing, like, what is my blood pressure? What is my cholesterol? Am I diabetic? Am I pre-diabetic? And kind of having an appointment to go over some of these things. And if I am, like, what is it that I should be doing to make myself healthier? So we touched on the alcohol thing. I mean, I think in Huron County or just general rural Ontario, right? Very common, 1 beer after work, 1 glass of wine with dinner. That's how we kind of relax. But our most recent guidelines are kind of showing that, the very excessive alcohol, that causes liver disease. We know that. But these more moderate consumption of alcohol increases our risk of cancer, but also all the vascular risk factors. So the current kind of recommendation is no more than 2 per week, which is a big difference for a lot of people. So managing our stress, there's so much you can do on this topic. I put a link at the bottom to a podcast called The Science of Happiness, which I think is very helpful for people. But even just one quick little thing is writing down every morning in a journal what you're grateful for. Like, it sounds silly, but reflecting on the things that are going well for us, the things we want to do more on, can shift our whole intention for the day and make things look more positive. The challenging your brain, I mean, I think the thing we see, oh my goodness, I apologize to everybody, is just that, we come home from work, we want to relax, we go and we scroll, we put on the TV. That type of a routine as a way of, rewarding our brain is not particularly healthy, right? Like, it would be better if we all read a book for 15 minutes, or we played a game, or we colored a picture, or, any of those things that use different parts of our brain would be a better health behavior for reducing that risk of cognitive impairment. So what can we do in rural, right? Like, what's the connection here? So we have to sort of think a little bit about what are our barriers to physical activity? Like, why are we lower in our physical activity? Things like, can we create safe walking and biking routes for people, where they don't feel like they're going to get hit by a car if they commute to work? Can we create indoor spaces for activity, green spaces? How can we promote activity in our youth? We want to keep community participation and social participation alive. Like, we want people to volunteer. We want them to be engaged in communities. Churches used to be the hub of our social scene, right? That's shifted. So how are we gonna adjust to that, and what are we gonna do? We want to communicate with people. Like, I think so many people are kind of communicating with their internet, like scrolling their Facebook, all these people and what are they doing and that kind of thing. But we're missing like what's going on right outside our door. We need to have access to primary care. Again, talking about all those vascular risk factors, and we need that health prevention education around helmets and hearing protection and all of those good things. So I think I'm pretty much at my time, so we'll pause there, and if I ever get the chance to speak again, we'll talk a little bit again about sort of the gap to care in rural areas for older adults, but I just want to thank everyone for their time today.
We have time for one question before we move
Okay.
on. If anyone's got a question for Dr. Peel. Maybe Mac has a question.
Do you have a question, buddy?
Yes, Gwen?
Just want to ask Dr. Peel, any ideas why rural a little higher?
For prevalence and incidence of dementia, like I think it comes back to a lot. Hello, buddy. How may I help you? Thank you for coming here. You help. So Gwen's question is, why is the incidence and prevalence of dementia a little bit higher here in rural than urban settings? So Gwen, I think it does come back to kind of some of those factors we talked about. So one is, across the board, we will have more older adults in our community. That's the demographic of a rural area compared to an urban area. So therefore, we'll have more cases. That incidence piece, the hypothesis is that it comes back to those some of those modifiable factors, right? There's emerging evidence about environmental factors. So, we may find trends over time if we were to actually study it, right? So, people have shown that Parkinson's disease is higher in farmers. They're not sure, like, is it something to do with the animals? Is it something to do with pesticides? Like, where does that come from? But we may find something similar with dementia. Like, I don't know. So those would be the key things I would highlight. Sure, I brought, Randy and Jeanette brought the books on preventing dementia, and I also brought books on healthy aging and things you can do to age well. You're going to pass that out? Perfect. I should have had you do that during the presentation. Thanks. Well, okay. Okay, thanks everyone. Take care.
Great. Thank you so much, Dr. Peel. That was excellent. I'm just going to queue up the slides for our last speaker. So our last, but certainly not least speaker of the session is Deb Shelley. Deb has an MA in community music from Laurier and a certificate in loss, grief, and bereavement from the University of Western Ontario. As a volunteer coordinator with Huron Hospice, Deb combined her passions for meaningful palliative care and grief support with the intentional use of music in care. Since the spring of 2018, Solace Bedside Singers have provided a musical blanket of comfort to individuals nearing end of life and those who support them. Whether in Huron Hospice, Bender House, Jessica's House, people's living rooms or front yards, bedside of a hospital, at a hospital bed, or at a funeral or graveside service, or a specially designed moment of solace pre-Christmas services, the members of Solace try to be sensitive to the needs of those receiving their songs. The group always offers their music as a free gift. So please join me in welcoming Deb Shelley.
Thank you so much. This has been such a great morning. So much learning going on here. I've invited 3 members of Solace to join me here this morning to give you a little taste of what we do. So we're going to get right to it. There will be time. Am I at the right? Oh, in my face. For questions and answers at the end again. So why even think about introducing music into care? We're going to start that conversation by having Solace members come and demonstrate what they do. So I invite you to just get comfortable in your seat, close your eyes if you'd like to. You can even fall asleep, that's okay. You can perhaps imagine yourself either sitting at the bedside of someone who is approaching death, or you can imagine yourself as the person in the bed. Solace will sing 2 songs. There's no need for applause. All emotions are welcome, as is silence or singing along. I'll draw you back into this moment now. What are some adjectives or descriptive phrases that you would use to describe yourself during those moments? You can share some if you want to. Sorry? Mortal, comfort, grateful, connection. In experiential moments such as these, we recognize that music is a powerful tool. And as care providers in various care settings, we have the ability to tap into music's helpful power. It's simple, cost-effective, and customizable to the whole person care that we offer day in and day out in our work. Perhaps you're already familiar with research done in this realm, from improving mood to providing a means of expressing difficult subjects, such as we just did. Music's effects have been researched and well documented. So armed with experiential knowledge and scientific research as a basic foundation, Huron Hospice decided it was time to take music's role more seriously. By way of background, Huron Hospice has been providing home visiting support throughout Huron County for about over 25 years. The catchment area services about 60,000 individuals. In 2017, the organization was able to purchase what is now known as Huron Hospice Bender House and has just now become a 6-bed hospice residence nestled on the 12 acres just outside of Clinton. Huron Hospice has grand goals and ideals. We ask ourselves, what do we need to do to improve the quality of life and care we provide to every person we serve? What does it mean today to be a rural center of excellence? And what will it mean tomorrow? How will we know when we get things right? Since about 2018, we have valued the time that various community musicians have taken to share their music occasionally in our residence. More recently, we started asking, what can we do to make sure that music is used with intentionality and consistency as an integral part of care? How do we create sustainable, meaningful music care? What training can we provide our volunteer musicians, both to give them a solid understanding of why music works and to heighten the value of their music moments with our residents? What can we do to create a shared vision of the precious value of music and care among leadership, staff, volunteers, and fundraisers? So asking these questions while witnessing positive outcomes from random music moments motivated us to explore Music Care Certify. Where to start? We created a Music Care site team. These individuals agreed to meet, take training, plan, take on various roles such as record keeping or music care resource curation, and to help design and implement our research project. With assistance from nurses and volunteers, our first task was to collect information on our soundscape. Just what were people hearing every moment of every day and every night while in Bender House? This then informed our next question. What would you want to hear if close to death and confined to bed? After getting some basic training under our belts, we looked to create a sustainable music care program. We explored what we felt were our enablers, such as motivated and talented musicians and engaged staff, and our barriers, such as lack of shared vision of music's integral role in care. As our awareness of both those elements grew, our research project questions were formulated. Are there observable positive outcomes in the recipient's demeanor to the offering of personal live music and care? And how does engagement in observing these things impact the attitude or perspective of on-duty nurses toward music offered intentionally as part of care? And we wondered, could we observe these things ourselves? Would observing outcomes increase a sense of shared vision with staff? So, a soloist, a duo, and soloist bedside singers were all invited to attend Bender House 3 times each during the month of November last year. November. Almost a year ago. We ended up providing 10 singing opportunities over the course of 5 weeks. We did not seek feedback from residents or their visitors. Musicians and nurses simply observed what we saw. So we created simple observation cards, one style for use by every musician and another for use by the nurses willing to participate. Musicians were invited to note. You can see our rooms are named by, those who can see the screen, named by trees. So birch, maple, spruce, and willow were the 4 different rooms. And then musicians could circle what they noticed, what they observed when they were singing in each room. And we left room on the back for lots of other comments. Sorry, this one's a bit blurry. The nurses had their own cards, so they would have 1 card for each room and could make note of what they observed in the resident post-sing. They would have been in the residence room prior to the music happening. I have a handout at the back that includes samples of these things too, if anyone's interested in those. In summary, though, our observed results concur with research previously conducted on the power of music in care. It works. Musicians reported observing 75% of recipients engaged, 69% smiled or sang along, 63% relaxed, and 50% asked for more. And from the nurses, they observed a staggering, to me, 100% increase in happiness in the residents. 83% were calmer or talkative or wanted more, and 67% were comforted. So those were our data results. The spontaneous, unsolicited outcomes of the project are what surprised and delighted us. And a few of these are: all of the musicians involved in our research project are now determined to offer their music more than once a month. Some do so weekly. Our musicians have grown more observant while singing. They watch for details such as slower, calmer breathing, or intentional eye contact, or someone choosing to sing along, or requesting a specific song, or tapping a hand to the beat. We see the ripple effect. For example, a BC relative of one of our musicians, after viewing our research results, decided that she would increase her visits to her local hospice. We started looking for other opportunities to engage musically with our clients beyond the walls of the residence. One of our musicians began arriving at a local long-term care facility to sing with her client who had dementia. Other folks in that home wanted to join in and sing along. See if I can do this.
The chorus one more time. And he walks with me and he talks with me and he tells me I am his own, and the joy we share as we tarry there, none other has ever known.
This is the tricky part. You get
The
past.
chorus one.
There we go. That music moment, we did receive permission to share that, by the way. That music moment was captured just weeks before this gentleman died. He would look for her, for Billy, actually one of our volunteers that's here today. He would watch for her coming, or when he saw her coming, he would waken and light up and just be so involved and engaging with the music. Sometime we could do a presentation on the power of music and dementia. I'd like that. With assistance from Jack, we introduced music care on 2 occasions in one of our grief support groups with profoundly connecting results. Of particular significance, our mindset moved from how do we get the nurses on board to how can we support our nurses? For starters now, musicians try to offer them their own music moments after they're done singing for residents. And we gave them 2 original self-care songs at Christmas to encourage them. We're growing in our appreciation for our nurses and for the music moments they might engage in while providing clinical care. So I invite you to watch 2 more short videos. The first is an excerpt from an interview with Krista, one of our nurses, and the second depicts a moment referred to in Krista's interview.
Outcomes have you seen in our residents or family members as a result of music?
Peace and calm and tears and laughter. Specifically when my aunt who's here, I can make mention of that because I sat with her. She tapped her hands to the music the whole time and was quite hard of hearing. I watched Jack's mouth move and just enjoyed it immensely. And she was having trouble breathing that morning, and Jack came in and played a song, and she just calmed right down.
Lovely. Anything else that I should know?
nurses sometimes sing.
Well, tell me more.
At the bedside, yeah.
Okay.
We sometimes just burst into song for no reason.
So part of the problem with that is we're not here to witness it.
That's good.
We don't. We don't realize that's going on. That's lovely. Can you think of a song that you've burst into bedside before?
Mamma Mia.
Would it be like if a resident asks or mentions something and it just prompts you to?
Yeah, just start singing. Yeah.
That's awesome. And that was the woman that Krista spoke of in the video before. Over the past year, I've been delighted to observe the Music Care site team grow in their understanding of music and care and in their confidence as musicians through their training sessions and research engagement. And it's been delightful to hear the stories from our nurses and musicians about the powerful impact of meaningful music moments. One such story is also included in the handout that you're welcome to. As Huron Hospice further develops the world of music care possibilities ahead of them, since I'm retired now, I am now available to voluntarily support the Music Care site team as needed. And my retirement from hospice now permits me to explore the world beyond. Music has been part of care for a long time. We know that music care works. Music's power is not only for the dying and their loved ones. Imagine the potential of intentionally developing its use in other care settings. A healthy community is represented by a wheel that runs smoothly. Each spoke in the wheel, we happen to have 8 like our square, contributes to that momentum. And every single spoke could benefit from intentionally and thoughtfully including music for the people being served and the ones who serve them. Goderich is already a music-rich community. However, most music offered is limited to performance space. We're planning to tap into our wealth of community musicians and offer them basic tooling in the value of offering their music as part of care. Meanwhile, we will connect with organizations and seek to engage with at least one in each of the spokes in piloting music care into the service they offer. If you'd like more information about creating a vibrant community through a Goderich Music Care Network, please speak to me. There are also Solace business cards available at the back that have my contact information on them. So I have to ask the question, why do we even want to do this? And the answer is captured beautifully in a new book I discovered on the shelf recently while working at Fincher's. Also, I needed a music care moment at the hospital the other day. It would have been nice to have someone playing guitar or keyboard in Emerge. Just saying. Why do we sing? This would be tricky with wrong finger. Okay. Why do we sing? Hum a tune, belt out a melody. Why do we make music with our voices? Well, let's just see. We sing because we're happy, or to say, I feel strong. When we sing together, we know that we belong. A song can help us fall asleep or say, I love you. Shepherds sing it to their sheep. Yodelay, yodelay, hee-hoo. I should have you do that, Jack. Some sing to entertain a crowd, with friends, or on their own. Songs help us remember how to find our way back home. Anthems, shanties, chants, duets, carols sung by choirs. Melodies, both old and new, can be shared around the fire. We sing at parties, or in prayer, even in the shower. Some songs are just for fun. Some speak truth to power. Sorry. Every song's important, and I hope now it's clear why we all love to sing so much. I just can't wait to hear. What will you sing?
Thank you very much. Would you stick
So
around for a question?
Yes.
Any questions for Deb? Yes.
We have been asked, so the question was, do we record our music so it can be played back? At this point, no, we have not. But yes, we contemplate that. Part of the challenge is it's the moment, right? It's the music in the moment with the people you're singing for and with that the magic happens. But that being said, I go to my phone and create a playlist, or you know, I mean, like we all have music that we want to go to. So I'll raise that question with Solace members again.
And you're coming up for.
Yeah, we'll do one more for you. Yeah.
Okay, great.
So we were going to send you out singing, but there's closing remarks after we're done here. So we'll invite you to join us if you'd like to. We're going to sing What a Wonderful World.
I see trees of green, red roses too. I see them bloom for me and you, and I think to myself, what a wonderful world. I see skies of blue and clouds of white, the bright blessed days, the dark sacred night, and I think to myself, what a wonderful world. The colors of the rainbow, so pretty in the sky, are also on the faces of people going by. I see friends shaking hands, saying, how do you do? They're really saying, I love you.
I hear babies cry, I watch them grow, they'll learn much more than I'll ever know, and I think to myself, what a wonderful world. Yes, I think to myself, what a
Great, thank you so much. That was very wonderful and lovely. Wow, what a great day or half day we had today. We got to hear. We started off with a dive back into history. We got to hear about things we can do to prevent diseases of all sorts and be healthy. We're able to learn about what you've done at the hospice and with respect to music and to understand the challenges for the our health system. I think with my pharmacy background, I think what inspired me the most was hearing about how people took cure-alls for everything, and that they were homegrown in Goderich. And you might find me on the square next weekend with a new one, because there's a big gap, and it'll cure everything. It'll be $65.99 per month. Okay. You won't have to. No, I'm just joking. So thanks again to all of the speakers that presented today. So wonderful. This morning's event wouldn't have been possible without all the amazing planning and organization from Gateway and Gateway staff. Special thanks to our AV and technical support for helping us through the day. And ensuring that we could share this great event, not just with the people in the room, but those watching online. Thanks to Huron County Museum for hosting us, and thank you to all of the sponsors. So that's all we've got for today. The next speaker series will be back in its online format on October 1st at noon. And so if you're online, you probably know how to sign up. If you're here, you can go to Gateway's website and sign up for the webinar, and you'll get a link, and you'll be able to participate in October's webinar and every month thereafter. So, and last but not least, thanks to all of you for attending online and in person. Really appreciate it.